The goal of this presentation is to explain how you should handle the transducer in order to achieve optimal quality in ultrasound scanning. Handling the transducer correctly is an important part of daily clinical ultrasound practice and should not be taken too lightly. Inaccurate handling of the transducer could lead to errors in scanning. Please hold the transducer with your first 3 fingers as shown in these 2 images. It's important to hold the transducer at its base, as this enables you to use your 4th and 5th fingers to make contact with the skin of the patient. This skin contact is important for 2 reasons. First of all, it improves the stability of the transducer. It prevents it from sliding away due to the ultrasound gel and ensures that one maintains a steady and controlled course of the transducer while scanning. The second reason is that the skin contact provides tactile input. The fingers that rest on the patient's skin feel the curves and shapes of the patient, which gives you the chance to adapt the transducer angulation to any changes. These 2 pictures demonstrate the incorrect method of holding the transducer on the left side and the correct method for optimal stability and control on the right side. On the left image, the sonographer is holding the transducer too far away from the base and does not have contact with the patient. As a result, the transducer is unstable and makes it difficult to follow a certain anatomical structure over a longer stretch. The image on the right demonstrates the appropriate hand position, where the sonographer has a comfortable grip of the transducer at its base with the thumb, index, and long fingers, while maintaining good contact with the patient's skin with the small and ring fingers, as well as the ulnar portion of the hand. These pictures demonstrate an excessive grip when holding the transducer in the left image and appropriate grip in the right image. In the left image, the sonographer is grasping the transducer with excessive grip, which results in increased difficulty performing smooth transducer movements during the examination. The right image shows an appropriate grip. This grip, a grip with relaxed muscles, allows smooth and easy transducer movements with good balance and also prevents undue strain during the examination. This image shows an inappropriate transducer grip. It is too high and with little stabilization. This image has been created for didactical reasons to clearly show the exact transducer position on the skin of the patient. The message of this slide is: place the transducer gently on the skin of the patient. Don't apply too much pressure, otherwise you are going to distort the shape of the underlying soft tissues or squeeze away fluid collections. In such cases, misinterpretation or misdiagnosis is possible. This picture demonstrates toggling of the transducer to change the angle of incidence of the sound waves on the tissue. Note that the position and the angle of the transducer changes from the left image to the right. This maneuver is used to reduce the anisotropic artifact. The angle is changed without moving the base to a different position. Simultaneous movement of the base while toggling should generally be avoided to prevent a confusing change of too many components of the image. These pictures demonstrate the heel-to-toe rocking of the transducer to change the angle of incidence of the sound waves on the tissue. Note that the position of the transducer is changed from the left to the right image. This maneuver is used to reduce the anisotropic artifact of tissue in long axis. With heel-to-toe rocking, the angle is changed without sliding the base to a different position. One important comment to the picture shown in this slide. When using the heel-to-toe maneuver, try as much as possible to keep contact with the patient's skin. The heel-to-toe maneuver in the left image and the toggle maneuver in the right image require gentle movements, refined motor skills, and good coordination. The proper outcome is to reduce or avoid anisotropy as much as you can. As soon as you can see that the region of interest shows the highest ergogenicity possible, you can stop performing the maneuvers at exactly that point. Sonographers are known to be at an increased risk of developing occupationally related musculoskeletal pain or injury. Results indicate that, although all the investigated scans involve injury risk, the specific risk factors and their relative importance varies between scan types. Make sure that your wrist is not being forced in end range angles or ulnar or radial deviations as shown in these two images. Always ensure that you have a comfortable grip, a fairly neutral wrist position, and low muscle tone. Not only the wrist is a risk factor when scanning patients in a non-ergonomic way, but also the shoulder and neck region. The left image shows a sonographer scanning a patient with large shoulder abduction and elbow extension angles, which produce a long moment arm at the shoulder joint. The right image, a more appropriate situation, shows a scan which results in a small shoulder abduction angle and a large elbow flexion angle, which produce a short moment arm at the shoulder joint. The bottom line is this: think about your ergonomic situation and try to optimize it as much as possible. Be aware that when performing many scans, the repetitive movements and static positions could lead to musculoskeletal discomfort or even injuries. Make use of good ergonomics to provide a comfortable position for both the examiner and the patient to improve the ease of scanning. Thank you for watching.
The goal of this presentation is to explain the operator-dependent variables of the 3x4 scanning quality checklist that should be used in daily musculoskeletal ultrasound clinical practice. Using this checklist will ensure that you scan your patients in a critical and qualitative way and that you lower the risk of false positives and false negatives. Musculoskeletal ultrasound is heavily operator and experience dependent. To ensure scanning quality and to make scanning a little bit easier, we have developed this 3x4 scanning quality checklist. The checklist consists out of 3 major points to think of during scanning: the operator or yourself, the ultrasound system, and the transducer. Each of the 3 points have 4 sub-points that you will have to think about. By using this 3x4 scanning quality checklist, you won't forget the most important variables to create a proper ultrasound image. Let me first focus on the operator-dependent variables during musculoskeletal ultrasound scanning. The operator or sonographer's position, the ergonomics, will affect image quality. A poor position will lead to unsteady transducer handling, not being able to reach the control buttons on the ultrasound system, and not being capable to scan for a longer period, which results in hasty work. All of this leads to poor image quality. This is an example of an inappropriate way of scanning. The sonographer has to reach for the patient as well as the machine. This creates an inefficient examination with undue muscle strain and fatigue. The area being examined is not in line with the screen. Attention to body position for both the sonographer and the patient can improve the efficiency of the evaluation and minimize strain or overuse. The patient should be placed in a position that provides easy access with the transducer and allows a comfortable arm position. Having to reach excessively can lead to fatigue, overuse injuries, and poor image quality. The patient should generally be placed between the examiner and the screen, allowing visualization of both. The machine should also be close enough to allow easy access to the controls without excessive moving. Attention to these details can make the scanning experience much easier for both the sonographer and the patient. When starting to scan, one of the first things to do is to apply ultrasound gel to the transducer. Without gel, the image will be of poor quality due to air interference situated between the transducer and the skin. Air is a very bad conductor for the ultrasound beam. Applying gel between the transducer and skin avoids and limits the interference of air. This image has been created without the use of gel. See how dark the image looks and how few details can be seen. This image shows much more detail and brightness due to the application of gel on the transducer. Always make sure that there is plenty of gel present. It not only serves to prevent the interference of air, but also enhances the gliding possibilities of the transducer when sweeping the transducer around the region of interest. As soon as the gel dries up, please add additional gel again. If you would like to scan a certain anatomical structure or tissue, make sure that you're scanning this actual structure or tissue. This might sound obvious, but trust me, this is harder than you might think. Many structures or tissues in the human body look alike, especially when the observer, the sonographer, is not experienced. The goal of this image is visualization of the transverse flexor pollicis longus tendon, and it has actually been scanned. The hyperachoic tendon is pointed out by a yellow arrow. When new in the field of musculoskeletal ultrasound, the most important thing is to build up experience by scanning many people. Experience in scanning a particular structure or tissue results in seeing this particular structure or tissue in many variations. This experience translates into a fictive ultrasound library in your head. This ultrasound library contains many images. Experience in scanning teaches you how a structure or tissue should look like and where to find it. When searching a specific structure or tissue, please use your own ultrasound library for comparison. When scanning, you would like to have a good overview of the whole region. You don't only wish to see the region of interest, but also the structures and tissues surrounding it. It's important for your diagnostic or evaluative process and your clinical reasoning to see the overview, the functional relation, and to see the quality of all structures and tissue visualized. Therefore, the region of interest should be centered. Centering the region of interest on the screen and maintaining that position during live scanning is a transducer skill that should be practiced when first starting to scan. It's also needed to prevent the desired image from repeatedly drifting out of view when scanning more rapidly. This image shows a transverse flexor pollicis longus tendon on the right side of the screen. Everything to the right of this transverse flexor pollicis longus tendon has been cut off. The only structures and tissues that can be assessed are the transverse flexor pollicis longus tendon itself and everything on the left side of the tendon. Hence, this image provides only half of the information that is needed. The same situation goes for this transverse flexor pollicis longus tendon, which has been visualized on the left side of the screen. Everything to the left of this transverse flexor pollicis longus tendon can't be assessed. The appropriate way to visualize this transverse flexor pollicis longus tendon is to place it exactly in the middle of the screen. Now we have a nice overview of the entire situation. We can assess the region of interest, but also the structures and tissues surrounding it. We can see the overview, the functional relation, and the quality of all structures and tissues visualized. Thank you for watching. The goal of this presentation is to explain the system-dependent variables of the 3x4 scanning quality checklist that should be used in daily musculoskeletal ultrasound clinical practice. Using this checklist will ensure that you scan your patients in a critical and qualitative way and that you lower the risk of false positive and false negatives. The system variables are the second point on our 3x4 scanning quality checklist. The 4 system variables to constantly check and adapt are the focus, the gain, the depth, and the frequency. Let's go over them one by one. The region of interest should be focused. By focusing the region of interest, the greatest degree of clarity is obtained. Not focusing on the region of interest results in a less clear image. Although it might seem like the difference between focusing and not focusing is small, it has been proven in clinical practice that these small changes are in many cases crucial in deciding whether there is pathology present or not. An unfocused ultrasound beam leaves its source and continues at approximately its width for a particular distance before it starts to diverge. The region close to the source, in which the beam remains narrow, is known as the Fresnel zone or near field. This is the region where the majority of the incident sound waves converge to create the greatest degree of clarity. The narrower the Fresnel zone, the greater the resolution. The region beyond the Fresnel zone, in which the ultrasound beam has started to diverge, is known as the Fraunhofer zone or far field and is associated with poorer lateral resolution due to beam divergence. The focal point is the horizontal line on the screen that should be placed at the level of the greatest interest on screen. The focal point refers to the location where the ultrasound beam converges to provide the greatest level of clarity. In reality, the focal point is not a precise point, but rather a focal zone where resolution is high. When scanning an anatomical structure, which is narrow in the plane parallel to the ultrasound beam, the focal point can be set at the level of the structure in question. Every ultrasound machine will have some sort of control over the focal point, the position of which is indicated on the depth scale. This image shows the focal zones on the right side of the screen in yellow. The yellow focal markings are pointed out by the red oval. This alignment of focal point with the anatomical structure in question seems intuitive and will give good results. However, where most people get unstuck is the positioning of the focal point when scanning a structure that is much wider in the plane parallel to the ultrasound beam. For example, if it has a significant depth on screen. Intuitively, most people will position the focal point at the midpoint of such a structure. However, the focal point will correspond approximately to the deepest part of the Fresnel zone, and as such, any part of the image deep to the focal point will lie within the Fraunhofer zone with associated beam divergence and poor resolution. Consequently, Much better results will be achieved by placing the focal point roughly leveled with the deepest part of the structure to be examined. Everything above this level on the screen will be within the Fresnel zone and will therefore lie within the region of relatively high resolution. Failure to maintain the focal zone in the proper location while scanning will result in decreased resolution at the point desired. More than one focal zone can be used if the area of interest is larger than the single horizontal level. However, additional focal zones tend to decrease the frame rate. The frame rate refers to the speed in which the image regains clarity after the transducer is moved. For this reason, too many focal zones make the image harder to see when the transducer is moved rapidly. This image has two focal zones, but it's more common to use one focal zone. This image shows two focal zones at exactly the same level as the hyper-echoic supraspinatus tendon shown in the middle of the screen. The gain increases or decreases the brightness of the image. The gain is typically set to provide the right contrast between the tissues being observed. This is often a matter of preference, but extreme values of high or low gain should generally be avoided. This image shows a scan of the transverse pollicis longus tendon with almost 100% gain. Due to an excess value for the gain, the entire image turns white. This results in loss of intra-tendon architecture visualization. Also, it obscures all hyper-echoic details because everything turns white as well. This is the opposite. The level of gain has been decreased to almost 0%. Due to a smaller gain, the entire image turns dark. This results in loss of intramuscular architecture. Also, it obscures all hypoechoic details because everything turns dark as well. Improper gain levels result in less visibility of intrastructure architecture. This is an appropriate image where all different gray values are balanced out and where all different tissues are clearly visualized. You might wonder then, why is there a gain setting at all? Why don't all people scan with a preset gain percentage? The answer to that is that the sonographer has to adapt and optimize gain or brightness levels to each individual as it depends on body composition. The sonographer should also adapt and optimize the gain or brightness levels to each anatomical structure within a person. People who are new to musculoskeletal ultrasound tend to scan with a gain setting that is too high at the beginning. Please keep in mind the balance. The depth should be set at the level that places the region of interest in the majority of the screen. This is an inappropriate image because the region of interest is scanned with a depth of 1.5 centimeters. This results in a region of interest which lies at the bottom of the screen. Everything below the region has been cut off, which results in less visualization of the entire region. If the depth value is too low, the desired image could be truncated, or there can simply be insufficient contrast from surrounding tissues to provide adequate perspective. This inappropriate image shows a region of interest that has been scanned at a depth of 6 centimeters. Too much depth results in the desired image appearing too small, resulting in a loss of intra-architectural details. It also leads to wasted space. The sonographer could have used the entire screen to visualize the region of interest. This is a correct depth for the demonstrated region of interest. The transverse pollicis longus tendon is visualized at a depth of 2.2 centimeters. There is a nice overview in good contrast over the entire tendon and surrounding structures. Higher frequencies are used for the resolution of more superficial structures. and lower frequencies are used for better tissue penetration. There are no hard and fast rules regarding the precise frequency for each specific depth, as it can vary due to a number of factors, including tissue thickness. A general rule is that the highest frequency that provides adequate tissue penetration and visualization should be utilized. The wavelength and frequency of ultrasound are inversely related. For example, ultrasound of high frequency has a short wavelength and vice versa. Medical ultrasound devices use sound waves in the range of 1 to 20 MHz. In musculoskeletal ultrasound, this is generally between 6 and 18 MHz. Proper selection of transducer frequency is an important concept for providing optimal image resolution. High-frequency ultrasound waves, or short wavelengths, generate images of high resolution. Increasing the number of waves of compression and rarefaction for a given distance can more accurately discriminate between two separate structures along the axial plane of wave propagation. However, high-frequency waves are more attenuated than lower-frequency waves for a given distance. Thus, they are suitable for imaging mainly superficial structures. Conversely, low-frequency waves or long wavelength offer images of lower resolution, but they can penetrate to deeper structures due to a lower degree of attenuation. In other words, higher frequencies are used for superficial structures. Higher frequencies provide a higher resolution. Disadvantage of higher frequencies is that deeper structures cannot be scanned with high resolution. Lower frequencies are used for deeper structures. Lower frequencies provide a lower resolution. The image is of poorer quality. But the compromise is that it's capable, in contrast to higher frequencies, to scan these deeper structures. As an example, we could state that a median nerve in the carpal tunnel, a very superficial structure, is preferably scanned with 18 MHz and a hip joint with 6 MHz. Thank you for watching. The goal of this presentation is to explain the transducer-dependent variables of the 3x4 scanning quality checklist that should be used in daily musculoskeletal ultrasound clinical practice. Using this checklist will ensure that you scan your patients in a critical and qualitative way and that you lower the risk of false positives and false negatives. The transducer variables are the third point on our 3x4 scanning quality checklist. The 4 transducer variables to constantly check and adapt are the positioning, the handling, the angle, and the optimization. Let's go over them one by one. The image should be orientated in a reasonably consistent fashion. By convention, when a structure is imaged longitudinally in a long axis view, it is typically orientated so that the left of the screen is proximal and the right of the screen is distal. There is generally less convention with respect to imaging structures transversely or in short axis. Some maintain the left side of the screen as the anatomic right, and others orientate the left of the screen as the medial aspect of the body. It is probably best to perform transverse or short axis live scanning in a position that makes sense with the orientation of the patient with respect to the screen. For example, when the transducer moves in the medial direction on the body, it should move the same direction on the screen. In the upper left screen of ultrasound systems, a little symbol can be found. Each ultrasound system brand shows a different symbol, but the concept is the same in all. This symbol correlates with a marker on the side of the transducer. In some cases, it's a small LED light. In other cases, is just a small plastic ridge, as seen in this image. Everything which is scanned with this side of the transducer will be visualized on the left side of the screen. To conclude, I mentioned on the previous slide that when a structure is imaged longitudinally in long axis, it is typically orientated so that the left side of the screen is proximal and the right side of the screen is distal. To obtain this, the transducer should be placed on the skin in such a way that the transducer's LED light or plastic ridge points to proximal, because only then will proximal parts be visualized on the left side of the screen. This slide shows a longitudinal scan of the long head of the biceps brachii. The transducer is placed on the skin in a way that the marker on the transducer is pointing to proximal. The obtained ultrasound image on the right shows the intertubercular groove, the proximal part on the left side of the screen, and the humeral shaft, the distal part, on the right side of the screen. In a previous presentation, you have learned about how to handle the transducer. We have dedicated a separate presentation to this topic because handling a transducer correctly is extremely important to scan with good quality. In the Handling the Transducer presentation, we gave you lots of tips and tricks on how to hold a transducer. For example, these two pictures demonstrate the incorrect method of holding the transducer for optimal stability and control on the left side, and the correct method on the right side. In the left image, the sonographer is holding the transducer too far from the base and does not have contact with the patient's skin. In this way, the transducer will be unstable and it will be difficult to follow a certain anatomical structure over a longer stretch. The image on the right, the appropriate hands position, shows a sonographer with a comfortable grip of the transducer at its base, with the thumb, index and long fingers, while maintaining good contact with the patient with the small and ring fingers and ulnar portion of the hand. Make sure that you have seen the Handling the Transducer presentation. Scanning with the correct transducer angle is probably the most important thing of the whole 3x4 scanning quality checklist. Scanning needs to be done perpendicularly, under a 90-degree angle. This is important to avoid the artifact anisotropy. In case of anisotropy, there will be, due to the incorrect angle of incidence, a smaller return of sound waves to the transducer, which results in decreased clarity of the image. The yellow arrow points out the transverse pollicis longus tendon, which is scanned under approximately 81 degrees angle. Please note that the tendon is very hypoechoic due to anisotropy and that it's almost invisible. Looking at this image, you might think that there is no tendon at all and that it's torn, but it's just obscured due to the anisotropy. The tendon becomes slightly more visible when tilting the transducer more towards 90 degrees. Because the tendon is being scanned at approximately 84 degrees, it still looks hypoechoic. A common pitfall would be to think that the tendon shows degeneration instead of realizing that the anisotropic artifact produces the hypoechoic color. Scanning at roughly 87 degrees shows a proper tendon, but still more hypoechoic than it should be, possibly leading to the assumption that it's not of 100% quality. Scanning the tendon perpendicularly under a 90-degree angle will lead to the most optimal image. Please note that the tendon is beautifully visualized with maximum echogenicity and that we can conclude that the tendon is healthy. Overshooting the tendon, for instance scanning under a 93-degree angle, again results in a little bit more anisotropy. If this happens, tilt the transducer back to 90 degrees. The angle of the transducer's position is always referred to the anatomical structure that you have to scan. It's not related to the skin. This image shows a transducer that has a perpendicular 90-degree angle with the skin. But the artery and nerve, which it should scan, are scanned under an incorrect angle of incidence, leading to anisotropy. If you would like to scan this artery and nerve optimally, then the transducer has to be tilted to the point that it scans the artery and nerve perpendicularly. Always search for the highest possible echogenicity of an anatomical structure or tissue. If the echogenicity is maximal, only then you know for sure that you're scanning perpendicularly. Following a certain structure or tissue over a longer stretch results in constantly adapting the transducer angle to the new location. Ultrasound is a very dynamic technique. All these variables should be adapted and optimized to every new movement or new transducer position. You should know these variables by heart and constantly and automatically, almost robot-like, be optimizing them to acquire the best images. Therefore, one of your hands holds the transducer on the patient, your other hand is near the ultrasound system buttons. All system settings are optimized with the one hand, while the other hand adapts the transducer position to the regions of interest. Thank you for watching.